This is Ashley Gerard, and I am recording my student assessment video number 2. So I'm going to begin my assessment with the lungs. So the first thing that I'm going to do is I'm inspecting the anterior and posterior chest. I'm looking at the shape of the chest, which is slightly curved, which is normal. Looking at the size, which is in line with the rest of the body. Ideally, the anterior-posterior diameter should be slightly double than the slightly twice that of the thoracic diameter, which it appears to be in this patient, which is a normal finding. I'm then going to look at the color of the chest, of both the anterior and posterior thorax, which is slightly pink in this patient, which is in line with the rest of the skin of the body and a normal finding. I'm also looking at the symmetry of the chest, both from side to side, and looking for a symmetrical rise and fall of the chest, and it does appear to be symmetrical. I'm also looking at the respiratory rhythm, which appears to be even and unlabored. The next thing I'm going to do is palpate for symmetrical thoracic expansion. And so I'm going to place my hands on the lower chest, and as the patient breathes, just feel for symmetrical expansion, and it is symmetrical. The next thing I'm going to do is palpate the skin of the anterior posterior chest, looking for masses, lesions, bulges, any signs of tenderness. And there does not appear to be any lesions, and there's no signs of tenderness. The next thing I'm going to do is palpate for tactile phreatitis, and I'm going to do that. I'm going to come behind the patient, and I'm going to place my hands on different spots of the posterior chest, of the posterior thorax, as the patient repeats 99. And I'm just listening for the resonance as he repeats that. So if you could just say 99 a few times for me.
99, 99, 99, 99, 99, 99.
And the resonance diminishes as I move down the chest, which is a normal finding. The next thing that I'm going to do is percuss the posterior chest, and I'm looking for both symmetry and resonance going down. Okay, so the next thing that I'm going to do, if you could turn slightly from here, turn your back to me. The next thing that I'm going to do is I'm going to percuss for diaphragmatic excursion, and I'm going to do that. I'm going to start with the right side, because it's closest to me, and I'm going to place my fingers slightly above the lowest point where dullness can be heard. And I'm going to percuss down until resonance becomes dullness. And I'm going to mark that spot. I'm going to do the same thing on the other side. And I'm going to mark that spot. I am then going to have the patient exhale completely. And I'm going to percuss up until that dullness becomes resonance. And I'm going to do that on both sides. Oh, are you still exhaling? You can breathe again. Did you exhale? Okay. And I'll mark that spot. I am then going to have the patient inhale and hold it. And I'm going to percuss down from the top until resonance becomes dullness, and mark that. You can breathe normally. And I'm then going to do that again on the other side. So inhale, and mark that spot. And so then what I'm going to do is I'm looking at from side to side. It should be generally even on both sides, but it's not uncommon for the right side to be slightly higher because of the presence of the liver. And it should be about 3 to 5 centimeters, which his is slightly more, but that could be because he's relatively fit. So we'll wash that off later. And so then the next thing I'm going to do is auscultate the anterior and posterior chest. Just take a few breaths for me. And I'm listening for the chest sounds. When auscultating the chest, I normally start at the bottom, especially in patients who may experience difficulty breathing, because you're most likely to have fluid gathering at the bottom of the chest, and that's where you're most likely to hear adventitious breath sounds. Just keep breathing for me. But breath sounds appear to be clear in all fields, which is the normal finding. So now the next thing I'm going to do is move on to my cardiovascular assessment. And the first thing that I'm going to do is inspect the chest for heaves, thrusts, or lifts. And I'm going to do that both while the patient is sitting up, and then I'm going to have the patient recline to about 30 degrees and inspect again. And I don't see any heaves or lifts or thrusts, which is normal. So I'm going to have you sit up again. And so the next thing I'm going to do is palpate the chest. I'm going to start at the second right intercostal. I'm palpating the chest, looking for any murmurs or the point of maximal impact. And so I'm palpating here, and then I'm going to go to the left at approximately the second intercostal space, down to the third intercostal space, and then the fourth, and then the fifth intercostal space at approximately the mid-clavicular line. And I should feel some slight thrusting here because this is the point of maximal impact, and that's a normal finding. The next thing that I'm going to do is I'm going to auscultate the chest. And I'm going to start with the aortic area, which is the second right intercostal space. And here I'm expecting the S2 heart sound to be more easily heard than S1. I'm then going to move on to the second left intercostal space, which is the pulmonic area. And I'm expecting, once again, S2 to be slightly louder than S1. And I'm then moving on to Erb's point at the third intercostal space. And here S1 and S2 should be approximately equal. And then I'm going to move on to the tricuspid area at approximately the fourth intercostal space. And here S1 should be slightly louder than S2, which is normal. And then to the aortic area at the mid-clavicular line at the fifth intercostal space. And here S1 should be greater than S2. And I don't hear any murmurs or clicks or any abnormal sounds. So then the next thing I'm going to do is palpate the arteries. And so I'm palpating the temporal artery. And I'm feeling for the rate, rhythm, and symmetry from side to side. So temporal and then brachial. And once again, rate, rhythm, and symmetry are all normal. And then the radial artery. And the same thing, rate, rhythm, symmetry. And then this is kind of hard to feel through clothing, but I don't want to have him take his pants off. And so I'm feeling for the popliteal artery. And the posterior tibial artery. And then dorsalis pedis. And I'm just making sure that the rate is normal, and his heart rate's about 65 or 70. Oh yeah, 65 or 70 rates per minute, which is normal, and it's symmetrical on both sides, and it's got an even rhythm. Okay, and so now I'm going to pan the camera around so that you know no steady aids have been used. And so now I'm going to move on to my assessment of the abdomen. And so I'm going to have him lay flat. And so the first thing I'm going to do is inspect the abdomen. And I'm looking for any striae, stretch marks. I don't see any there's no vasculature really apparent on the skin of the abdomen. I mean, some slight. I'm just looking at the vascular pattern. I'm looking for any lesions, hernias, like any bulges or masses. I'm looking at the general size of the abdomen, which is in proportion to the rest of the body. I'm looking at the shape. It's mostly flat, slightly rounded, but normal. I'm also looking at the color, which, like the chest, is pale, slightly pink, which is normal for this patient. It's in line with the rest of the color of the body. The next thing I'm going to do before I percuss or palpate the abdomen, I'm actually going to auscultate. So I'm listening for bowel sounds, and I'm going to listen. I'm going to all four quadrants of the abdomen until I hear positive bowel sounds. Okay, and there are bowel sounds present in all four quadrants, which is a normal finding. I am then going to auscultate the arteries that are present in the abdomen, and that's the renal artery, and then the iliac, and the femoral, which is a little hard to feel, but okay. And then the next thing that I'm going to do is percuss and measure the liver. And so I'm going to start. Oh, and I forgot to mention that when I was inspecting the abdomen, I was also looking at the umbilicus and making sure that it's midline and inverted, which it is, so it's normal. And so now I'm going to percuss and measure the liver. And so I'm going to start at the level of the umbilicus and percuss up until I feel dullness. And mark that point. And then percuss down until resonance becomes dullness. And mark that point. And do the same thing over here. And then I'm going to measure and note, centimeters. Measure and note the size of the liver. And this is about 10 or 11 centimeters, which is normal. I am then going to percuss the spleen. It's a little hard to find, but it's harder to find, but you shouldn't feel any enlargement in this area. I am then going to palpate the abdomen. So first I'm going to palpate the liver, and I'm looking for any tenderness or enlargement, which is not present, so that's normal. I'm also going to palpate the spleen. Which is here at the mid-axillary line. And then I am going to attempt to palpate the kidneys, but I'm going to be very careful while doing this and avoid deep palpation because I don't want to do injury to the kidneys. And so I'm going to, I'm going to lift and then try to palpate with the right hand. And like I said, I'm palpating gently and avoiding deep palpation. And I don't feel any enlargement and there's no tenderness present, which is a normal finding. And so that completes my assessment. Thank you.